First of all, I welcome each and every participant who has logged in and taken their time to for this beautiful CME web CME, which is a live right now. And today's speaker is Dr. Uday Phadke from Pune. As per he is a very well-known endocrinologist, diabetologist from Pune city. He has done his MBBS, MD, DNB, DM endocrinology, and also he is a fellow American College Endocrinology FACE. He is well-known specialist and also is a well-known speaker at various national as well as international forum, and also has contributed more than 500, conducted more than 500 CMEs and workshops for physicians across the country. He himself is an avid nature lover, known for his very much passion for trekking, traveling, and one more thing, that is the nature photography. So I'm not coming in between to our speaker as well as all the audience. So I request and hand over the session to Dr. Uday Phadke. Sir, all is yours now, sir. Thank you very much.
Thank you, Vinod. Thank you, Sanjay, for hosting this initiative. First, I think that we are talking to doctors across Pune. And good afternoon to all of you who have joined in. What I plan to do today in the next maybe half an hour is to take you a little bit about what's happening on the scene, what we know about COVID right now, particularly in terms of the patient characteristics, and a little bit about what doctors should be aware of when they are managing patients in the current scenario. And lastly, what we know about the association between diabetes and the COVID epidemic or the pandemic. This is an artist's representation of the thing which is creating havoc all across the world. And you'll see these spike-like things, which look like a crown actually, which have earned the name Corona or the moniker Corona to this particular virus. This is how it all started. Sometimes in December, an ophthalmologist in China started noticing, and he started reporting to his friends on a chat group, that he was noticing a peculiar kind of a viral infection, which he thought looked like SARS in presentation. You know that SARS had come previously also, and people were aware of how it presents. And this gentleman thought that this particular outbreak was something which was similar to what had happened in the past. I think he was not taken very seriously at that particular time. But then towards the end of December, cases started exploding and people sat up and took notice. And this is what is known as the novel coronavirus. As you can see here in the left upper corner, it's a very simplistic kind of organism. If I would, if you could even use the word organism, because it's not really a living thing. Just has an envelope which encases a single strand of RNA inside it. And there is, outside the envelope, there are protein spikes. And these protein spikes are the ones which allow this virus to attach to a particular host cell, enter inside it, and then replicate in multitude of copies, and then spread infection. The typical syndrome that it causes is predominantly respiratory in origin, although some degree of gastrointestinal symptoms are known. And from a small pocket in China, in the Hubei province, it is now spread all across the world. Now, the corona is not new to the medical community. We had the SARS virus epidemic in China in 2003, and we also had SARS in some other countries in Asia, but somehow it got restricted to certain pockets and died down. We then had, from the Middle East, particularly from Saudi Arabia, we had an epidemic, an outbreak of what we call MERS, or the Middle East respiratory syndrome. Again, it was due to a coronavirus. And now, of course, we have the 2019 coronavirus infection, and it's now called the novel coronavirus, because it seems that this old virus has undergone some changes after acting or after combining with a zoonotic host to change its own structure. And therefore, it is now known as the novel coronavirus. There are different types, but what we are predominantly the disease causing are the last three: the MERS-CoV beta, the SARS-CoV beta, and now the 2019 the coronavirus infection. Now, as I was saying earlier, it was on December 31st that the WHO was formally informed of an outbreak of pneumonia of unknown cause detected in Wuhan city in the Hubei province of China. And this is the seventh largest city in China with 11 million residents. Till at that point of time, it was thought that this was some kind of a minor influenza-like illness which could come and go. And people had not realized the significance and the severity and the gravity of the whole situation. But then, as cases started coming in, on December 31st, the Chinese authorities informed the WHO of this particular outbreak. The first infected individuals were actually the stall holders from the Wuhan, China seafood market, where, as you know, a lot of different different animals are actually sold to humans for human consumption. And I'm sure a lot of us, particularly in the early days of the coronavirus epidemic, have seen videos of this seafood market, and we have seen how different animals and mammals, the bats, were lying there to be sold. And in China, these are apparently delicacies which a lot of people eat. Subsequently, as people started realizing that this could be a kind of a zoonotic infection, the wet market was closed on the 1st of January 2020, and subsequently gene sequencing of this new Wuhan coronavirus underwent. This was a beta coronavirus. It was related to the Middle East respiratory syndrome virus and the SARS-CoV, or the severe acute respiratory syndrome. However, in terms of mortality and transmissibility, we still did not have a very clear picture as compared to the prior reference coronaviruses. We are now just out, starting to get a hang of how things are. And these are the typical symptoms that are coming in. They are actually quite common to the usual respiratory symptoms that we get from viral illnesses. There is typically a fever, which is often a little high grade. So it's at least 100 degrees Fahrenheit or 38 degrees Celsius or more. There is a dry cough with very little of rhinorrhea. This seems to be a kind of a characteristic. So fever with cough occurring within about 2 to 7 days after catching the infection, and typically some kind of a breathing difficulty, which will then sometimes progress to pneumonia. And if the viral load is immense, the patient quickly lands up into acute respiratory distress syndrome, a multi-organ failure, a shock. Secondary bacterial infection might set in, there is septicemia, and the patient succumbs. So apart from the usual respiratory symptoms that we are looking at, we are also sometimes now seeing patients who are getting gastrointestinal issues like diarrhea, and myalgia has been reported in several patients with the coronavirus. But again, myalgia is something which is not an uncommon thing with the flu-like syndrome that we often see. This is a chart, but by no means is this very exclusive. And you'll see here that the usual cough cold that we get versus the normal influenza virus infections versus the coronavirus infection, what we find here is that we are still not 100% sure about the incubation, but it seems less than 14 days now. The fever is very common. What is very common now is the persistent cough, breathlessness, which is kind of uncommon with the usual flu and the common cold that we get. And this breathlessness and the cough progressing to pneumonias is something which is the most important point in this, or the most important problem with the recent coronavirus infection. Now, this is the COVID-19 situation report coming today. As you know, the WHO keeps updating its information, and this is what we have got up to now. The good news is that no new countries, territories, or areas have reported cases of COVID-19 in the past 24 hours. So, a new country or a completely new territory which did not have COVID, say 24 hours ago, is not reporting it. It's good news. Although I would not say that we are over the infection yet, but at least in the last several days, I think this is the first good news that we are hearing. The WHO Director General has highlighted in his media briefing yesterday that there is an acute shortage of personal protective equipment. And I think as doctors, I think this is a very, very important thing that we need to look at, because this really has the ability to save the healthcare worker who is in the forefront of fighting this infection. I say this very sincerely because there are some people who expect us to continue our duties in the usual fashion without being protected. And if the healthcare workers themselves start getting infected, as we have seen in the United Kingdom and even Italy, it would be a really tragic situation, because if there are no doctors to take care of patients, it would be a complete chaos. So the WHO started shipping these individual items of PPE to several countries, and it will continue to do so. And what it has also done just recently is published the first edition of a manual to set up and manage a respiratory infection treatment center and a specific screening facility. So up to now, all the countries that are dealing or fighting with the coronavirus had their own protocols in place. They were using their own ideas, but now the WHO has put together a white paper on this, and we will have a unified guideline of how actually we need to set up these large centers, considering that we may get a large number of patients in the coming days or weeks or months. This is really open to conjecture right now. This is the current scene today. A total confirmed of almost 6,70,000 patients across the world have tested positive for the coronavirus infection. So I'm talking of positive tests. We don't know the actual number infected, but these are persons who have reportedly been positive, of which we have already got 1,42,000 patients. So roughly about 20% of patients have already recovered and gone home, which is a good sign again to all of us who are just being looking at the gloomy bad news every day. There have been deaths, about 30,000 odd, which roughly translates into about 3 to 4% of mortality across the world. And there are certain figures coming from India as well. India, as I speak now, has just crossed the 1,000 mark. We have had about 25 deaths. We also have patients, the initial patients who were reported have already gone home, most of them, but we still do have some critical ones on respirators being cared for, and a large number of these 1,000 patients are in different quarantine centers and being assessed locally. And this is a day-by-day bar chart to show you how the local spread has been. And if you see here, towards the end of or the last week of March, we had a sudden spate or an increase in the cases which are occurring locally with no specific travel history, and their contact was not clearly very well known, but then this is being looked into by the epidemiologists. But as you can see here, there is a slight decline since the last 2 days in the number of new cases that we are getting. Again, probably a good sign to look at, be optimistic. So this is the definition of a patient who will probably have COVID. So what we call them is SARI. SARI is severe acute respiratory infection. So surveillance case definitions currently are any person with a history of fever and cough, which is serious enough to require admission to hospital with no other etiology that fully explains the clinical presentations, which means that it's not a typical bacterial pneumonitis. But again, even in these patients, unless we test them for COVID, we wouldn't know. and any of the following, which includes a history of international travel, or if the disease occurs in a healthcare worker who is working in a hospital which is caring to patients with uh, people who have had history of travel or have history of SARI, or if the person in the course of a respiratory infection develops sudden deterioration without appropriate treatment. Again, we need to suspect COVID. And the second group of patients we need to suspect COVID is a person with acute serious respiratory illness of any degree who within 14 days of the onset of illness had any of the following exposures. So close physical contact with a confirmed case, or he is a healthcare worker in a country where hospital associated COVID infections have been reported. So in multiple metros, there are patients now in hospitals. So if this person is a healthcare worker and has a SARI, he is to be considered as a potential COVID case. And what does close contact mean? Close contact means that he is directly involved in the health care of a person infected with COVID, or he has been working together in close proximity with a patient or a healthcare worker who has developed COVID, or he has traveled together with a COVID-19 patient in any kind of conveyance, or is living in the same household as a COVID-19 patient. So these are the patients or the persons who are the highest risk of developing the coronavirus infection, and they will be very actively, or they are being very actively screened by the government authorities. A little bit about the clinical characteristics of patients. Particularly, we are getting data which is confirmed from China. From all other places, there are some case reports, but since China has had experience of this now for the last 3 months, there have been publications in international journals. And this is what we know as far from at least the Chinese experience. The median age of infection was about 56. There was a preponderance of men. Hospital-associated transmission was suspected as the presumed mechanism of infection for healthcare professionals, so 29%, and hospitalized patients about 12%. So, you know, it's not just that you need to have had traveled internationally, but you could catch it from a person who is infected and who is being treated in a hospital. So this is something which we doctors need to be vigilant about. So it cannot be said that just go ahead and do your routine duties without being aware of the risks that we are getting exposed to. We need to be careful about our own personal protective equipments when we go and see these patients, particularly with severe respiratory symptoms. The common symptoms, as I have alluded to earlier, included fever, fatigue and myalgia, dry cough, and in the laboratory evaluation, there was a very significant lymphopenia, which occurred in practically 70% of patients. There was a prolonged prothrombin time in many patients, elevated LDH, and what I've been hearing from other sources is that the ratio of neutrophils to lymphocytes is also something which is very important. So there are almost 3 times more neutrophils than lymphocytes, and the CRP is very significantly elevated. A number of patients have also reported to be having a high positive troponin T. In patients who have the evidence of low respiratory tract symptoms, so cough, severe fever, shortness of breath, the chest CTs showed bilateral patchy shadows of ground glass opacity in the lungs, and this was seen in all patients. Most patients received antiviral therapy. This is the Chinese experience, as I was saying. Oseltamivir, and many received antibacterial therapy as well, which consisted either of moxifloxacin, ceftriaxone, azithromycin, and some have required or been given glucocorticoid therapy. Although this is a bit still a bit of a controversy as far as the use of glucocorticoids are concerned. 36 patients in the Chinese experience, at least in this first paper, were transferred to ICU because of complications, including the acute respiratory distress syndrome, arrhythmia, and shock. And this arrhythmia and shock has been, the arrhythmia particularly, could be because of a direct myocardial involvement which translates into a higher troponin T. The median time from first symptom dyspnea was 5 days, to hospital admission was 7 days, and to ARDS was 8 days. So it's in the first week after the infection that things have rapidly moved ahead. And this is the CT imaging of the 2019 coronavirus pneumonia. You'll see here that the enhanced CT images show multiple ground glass opacities in bilateral lungs. They're seen in the posterior segment of the right upper lobe, apical posterior segment of the left superior lobe, and images obtained 3 days later showed progressive ground glass opacities in the posterior segment, right upper lobe, and also the left superior lobe. And this is typically bilateral. There is peripheral without subpleural sparing, and these are common CT findings. Now, one might actually ask why these are enhanced CT images and why no contrast CT was used. I have read now through the variety of information that is available that this was probably done to avoid the contrast-induced renal injury in people who are already pretty ill, and a contrast-induced renal injury might add compound to the problems and would not probably add much of information on the CT scans. Continuing further, the patients who were treated in the ICU compared with patients not treated in ICU were clearly older. This we now know that age is a clear risk factor. They were more likely to have underlying comorbidities. Almost 72% had underlying comorbidities and were more likely to have dyspnea and anorexia. So again, we are getting these some pointers that elderly patients, patients with underlying comorbidities, the ones who are presenting with shortness of breath are the ones who are probably likely to receive or require intensive care. Of the 36 cases in the ICU, 11% received high flow oxygen, 41% required non-invasive ventilation, and 47% received invasive ventilation. And again, I have been reading that a lot of patients will require invasive ventilation. The role of non-invasive ventilation is relatively less in this type of patients. And as I speak, a lot of ICU protocols on the management of intubation and ventilation strategies of COVID positive patients are actually being transmitted on the web as well. As of February 3rd, 34% of patients were discharged. 6 died. The mortality was 4.3%. And amongst those discharged, the median hospital stay was 10%. So it was a fairly rapid onset and offset of things. And this is something which we should be aware of again. These are the basic protective measures against coronavirus, and I'm sure as doctors you're all aware of them. Basically, social distancing, washing your hands with soap and water regularly, particularly if they're dirty. If they're not dirty, then a 60% alcohol containing solution is good enough. Cover your nose and mouth with handkerchief or tissue while sneezing, or you can sneeze into your arm. Wash hands before you touch your nose and mouth. Now, it's observed that an average person touches his nose or mouth at least 5 times every minute. So if we are touching other surfaces and then touching our face, this is going to be a problem. And of course, the used tissues have to be disposed into closed bins immediately after use. Of course, when you're dealing with a known COVID positive patients, these tissues have to be burned or buried according to the biosafety guidelines. And this is, of course, just to once more refresh the way of washing the hands. It's not just that you just put your hands under the water or the tap. It has to be properly rubbed all the nooks and crevices so that all the interdigital webs are also cleaned up. This has to go on with soap and water for at least 20 minutes. Now, these are some of the do's that you should be taking care of as a frontline worker. So basically, take all the preventive measures. You must make sure that if you're taking care of a person with respiratory syndrome, you have to cover your mouth and nose with a folded cloth or mask. Now, many of you have seen some videos being circulated on social media of a kind of a home plastic shield being prepared with the help of a plastic cover and a lace interwoven through it. These kinds of things are not the things to follow, because when we use a mask, we have to make sure that the mask sits snugly over our mouth and our face, and the nose is covered. We know as doctors how to tie the mask, but be sure that you wash your hands first and then tie the mask. And when you untie the mask, don't touch the front of the mask. Unwrap it from behind and dispose of the mask immediately. Maintaining safe distances is an absolute must, but in crowded areas, this is going to be a really difficult task for many people. The older people are at higher risk. So if you're taking care of an older people who does not have symptoms, but be sure that you also follow the hygienic principles, because you should not transmit any kind of respiratory infection to these elderly people. As I said, the WHO has started pushing out shipping the personal protective equipments to a large number of people. And I think all of us as doctors have to talk to our respective associations, the professional associations, for making PPEs available if doctors have to actually come to the forefront to fight this infection. This is as far as the COVID basic knowledge is concerned. This is not specific to diabetes. This is knowledge that is common to all patients who are all possible people who might get the COVID infection. Now, what is it about diabetes that makes it somewhat a bit of a grave concern? As I've seen earlier, the problem that diabetics face is a problem of worst outcomes, not greater chance of contracting the virus. So it's not that because someone has diabetes, he's going to get COVID. If he gets COVID, it's likely that he will develop more severe infection. People who already have diabetes related health problems are likely to have even worse outcomes. So if you have combinations of cardiovascular disease, hypertension, CKD on top of diabetes, along with say COPD, this is going to be a problem, and these people have to be looked at with a very, very high index of suspicion, and they have to be taken special care of. People with diabetes do face an increased risk of decay and also of hypoglycemia. And the decay could come, of course, typically in a type 1 diabetic, but when sufficiently challenged, an insulinopenic patient of type 2 diabetes, when he has a serious infection, could go into diabetic ketoacidosis because of the stress hormones being released in huge quantities. Now, decay is commonly experienced by type 1, as I told you. What is important to note is that viral infections can cause serious inflammation or tissue edema. And this tissue edema and inflammation is already present in a person, particularly with uncontrolled sugars, because hyperglycemia, as you know, is a clear risk for chronic inflammation. So if glucose control is poor, the severity of viral illness and risk of complications will increase. So typically what we need to do now is that we need to talk to our diabetes patients and encourage them to maintain a good glycemic control. This will help reduce the severity of infection. So those people who have self-monitoring blood glucose equipment at home should frequently monitor their blood glucose. And good glycemic control will not only lessen the severity of COVID, but will also reduce the chance of superadded bacterial pneumonitis, which is a clear fear. Those with coexisting heart disease and kidney disease need special care, and attempts should be made to stabilize their cardiac renal status. So encourage all your patients. So those people who have access to their patient database, send out messages to people, to your patients, not to forget their medicines, not to and to monitor their status of sugars, and to get back to you if they're facing trouble. Attention to nutrition and adequate protein intake is important. Now, when I say attention to nutrition, I mean both under as well as over nutrition, because when people are cooped up inside a closed space with nothing to do, boredom sets in and people start snacking, and this could be really risky for diabetics. As you know, people cannot really exercise as much as they used to because people are being discouraged to go out. So talk to your patients, tell them to do some kind of exercise at some point of time during the day, but do it regularly. It could be a variety of exercises that they can do, static exercises, some yogasans, whatever they would like. Walk around in the house, climb up and down the stairs, but it has to be done because exercise itself, as we know, improves immunity. It might be a good idea to take influenza and pneumonia vaccinations. This is already recommended in elderly diabetics, and this might decrease chances of secondary bacterial or influenza related pneumonitis after respiratory infections. Timely glucose management during hospital stay is absolutely necessary because the overall diabetics coming to hospital with COVID, the percentage of diabetes was about 20%. And because of the compromised immune response, the susceptibility to enhanced disease severity was clearly high. And of course, as I said, comorbid diabetes was associated with worse outcomes. So ICU patients with virus infection were more likely to have underlying diabetes. The mortality of COVID-19 patients was somewhere between 3 to 15%. So dramatically more, as you can see, as compared to those patients without comorbidity. So it's our duty, as you can see in the graph here, that those who do not have pre-existing conditions, as you can see here, their uh, chances of mortality is just less than 1%, 0.9% in fact. But as the number of comorbidities start increasing, this number can go up to 10 or 11% also. So particularly, go back to your patient databases, contact your patients with multiple illnesses, or if they are getting in touch with you, encourage them to monitor the disease and talk to you for advice. Again, this is something which is important. And I think this should be taken as a positive thing because as we look at the overall mortality rate and the severity rate or the severity by age group analysis, we see that it is patients who are actually in the age group of about 70 who have really suffered the most. Those between 60 and 70 are next on the list. But below that, we see a fairly small number of patients actually getting very severe infections. So we need to direct our attention to the elderly people in the house, in the community, wherever they are living near you. They are your patients and they need maximum amount of care. This is something which I've already alluded to, that the extreme stress hormone response to infections such as glucocorticoids and catecholamines may cause a variety of glucose variability, diabetic complications, dyselectrolemias, dehydration. So we need to really follow a good hydration protocol of these patients as well. Hospitalized patients need good glycemic control with aggressive insulin therapy. Typically, they go on to basal bolus regimens. ICU admitted patients will go on to a typical IV insulin protocol. And it's not just during the hospital, but even in the 4-week follow-up period after discharge, blood glucose should be maintained continuously. And this is essential to reduce diabetes-related complications and mortality. And how do we do that when our routine clinics are closed and we are not available for routine consultations? Fortunately, the Medical Council of India, just several days ago, has allowed the use of telemedicine, particularly at this point of time. And all of us now have access to internet, smartphones, good quality networks, and we can really take care of our patients who cannot come to us physically right now, but are willing to connect to us or who want to connect to us via the internet. There are also free educational videos and ebooks on diabetes self-management. And if you have websites, maybe you can put out some basic information to your patients on what to do. In China, this was done through the WeChat mobile app. They don't have WhatsApp, so WeChat is their
Yes.
popular method of communication. And the Chinese experiences that these online services and resources have played remarkable role in the nationwide COVID-19 fight in China particularly. A lot has been said about several therapies that are used for the coronavirus. We still do not have a very specific antiviral drug that we can use. And there has been the anecdotal use of drugs like lopinavir, ritonavir, interferon beta, and the RNA polymerase inhibitors like remdesivir, and of course, very popularly has been circulating in the social media networks, the use of chloroquine and hydroxychloroquine. Let me tell you that none of these are officially kind of sanctioned for use. Nobody has said to use this clearly by a particular guideline. But let me also tell you that the WHO has undertaken a very massive trial, which is internationally ongoing, which is called the Solidarity Trial, which will test a number of these drugs and the different cocktails being used. And we might get some basic answers in the next couple of weeks' time, I hope. This is not like a randomized controlled prospective trial, but this is a quick observation because we are not living in normal times right now. A lot has been said about the ACE inhibitors, and the whole idea came in because it's believed that the novel coronavirus has a receptor binding site and has a strong affinity with the angiotensin converting enzyme 2 or the ACE2, which lines the lung epithelia. And we know that this particular ACE2 is already upgraded and is the levels of the ACE2 are also increased. It's overexpressed in diabetics. And the typical drugs that we use, that the RAS inhibitors, also increase the ACE2 level. So there was some thought initially that using ACE2 inhibitors in diabetes or cardiac disease might be a problem. Now, the final word is not out on this subject, but let me tell you that the European Society of Cardiology had an emergency meeting of experts, evaluated all the data that is available on this subject, and at least the ESC said that at this point, there is no clear recommendation to stop the ACE2 in patients who are already using it and finding benefit. If you're trying to put new patients of, say, hypertension, then perhaps CCBs could be a better alternative. Again, something has been written on zinc nanoparticles. We don't know what the real role is. It has been said that it has some effect on COVID because it was shown to have some inhibitory effect on the H1N1. As far as chloroquine is concerned, we again have anecdotal reports coming from some countries that chloroquine has been found to be useful. And there are a variety of mechanisms by which this chloroquine is found to be beneficial. But again, we do not have a clear recommendation. And at least people who do not have any respiratory symptoms, signs, they are not high risk or contacts of COVID patients, just by some news on the media, don't start taking chloroquine is my advice to you. In all this uncertain gloom that is prevalent all across the world, it's the medical workers who are being pushed to their limits, particularly in areas where the COVID outbreak is really very serious. And the mental health of these medical workers in dealing with the coronavirus is also going to be a problem because nobody really knows how to tackle this devil and it's all uncertain. And these doctors who are fighting for their patients are themselves not certain what might happen to them. And this has caused, several things: frustration, isolation, negative emotions, a lack of contact with their families because they are working in the hospitals the whole day, and when they come back, they have to sort of self-isolate them. They're getting exhausted as well. This is bringing about stress, anxiety, depression, insomnia. And I know for a fact that there are several mental health consultants and psychologists who started online consultations for free for these people, healthcare workers, who may be facing some of these problems when they're dealing with this massive pandemic. So this is the current knowledge that I have about the COVID, and I am not saying that this is that I have complete or exhaustive knowledge of all angles of the COVID, but particularly from an angle of what we should do, particularly diabetic patients, and from a point of self-care as medical professionals, both physically and mentally. uh, I thought this was a good opportunity to share my thoughts. I really thank you for joining us today. Thank you for your time. Thank you for listening in.
Thank you very much, sir.
Uh, Wonderful. I think, yeah, Vinod, go ahead.
Yes, sir. Suhas has something. Yeah. I just request from audience, if there is any question, also they can ask by unmuting their screen, and they can ask so that we can ask the Dr. Phadke to just address those questions.
Hi, SV Kulkarni here.
Yeah, hello, sir.
Yes.
Good evening.
Yes, hello.
Hi, Uday, fantastic presentation. 25 minutes for the first part, and the rest of the things you well told in 23 minutes. The clinical scenario of using neutrophil to lymphocyte ratio is something, a very, very practical way of assessing severity of any URTI patient. If the neutrophil to lymphocyte ratio is more than 3.8, then these people are at a higher risk of developing complications. The second point which I want to add is all our patients who are diabetic and likely to suffer. So our aim should be the pill burden of these people, and in that context of anti-diabetic drugs. Otherwise, our patients will go on taking B complex, zinc, and other preparations, and they will forget their anti-diabetic drugs because the number of tablets are more. Any other question from the audience? Or
SV, you were going to share some.
Yes, I'm going to share the same PowerPoint. The first thing is there are certain applications in which you can just go on putting your symptoms, and it gives a probability that whether you are likely to suffer from COVID-19 infection or not. There is one developed by a chain of hospital that I share it with our audience, and it asks you a series of 10 questions, and then it can tell you that whether you are likely to suffer from, and whether you need any immediate consultation or immediate care. Another point is other comorbidities need to be significantly considered. Diabetes associated with hypertension, COPD, liver diseases. These are the conditions which are going to cause more problem. Even a simple anemia needs correction. The other point is, as Uday said rightly, there is a huge overload of information and many other tips of unscientific, unproven, or sometimes fatal things. You might have heard the stories of people who have suffered from complete heart block after using two drugs which have prolonged QT intervals. The best example is hydroxychloroquine and azithromycin. So please don't believe in magic cure. Follow the law of land. Encourage all your patients to keep social distance, isolated, and please use technology to its maximum. Even a simple white WhatsApp clinic also will do. I can see Navneet here. Navneet, can you add something for the way in which the technology can be used in care of all the diabetic
Before
patients?
Navneet comes in, I want to formally thank Navneet because he has been instrumental in putting together this presentation and helping us today also.
Thank you, sir. Thank you.
Great.
So one thing, I think I was listening to some of the international media channels. One person from Oxford, supposedly a leading person in psychology. I think the Western world is also parallelly concerned with the psychology. One person has an interesting word. That probably social distancing may not be the appropriate word. Physical distancing is the appropriate word. Social distancing should rather be should be linked with respect to the virtual communication. At least Facebook, WhatsApp, the communication is so strong, which will allay the mental the phenomena which will grow up down the line. I think social distancing should not be the thing. I mean, it should be taken up that virtual connect technology, as sir mentioned. It has to be used to its maximum. In the judicious way. Another thing, I'd like to point out that eliminate the rumors and the wrong information. We start believing without validating. Validation of information, despite a huge influx and inflow, which is infinite probably. We cannot manage the information load which is happening on a moment.
What people are doing is they're just spreading the doomsday predictions.
Yes,
we have mortality figures, passing them on to each other. And
each one of us, sir, each one of us should have a responsibility to minimizing the forwards without thinking.
Absolutely.
At least we should validate what is right, what is wrong, because implications can be manifold. We have seen the example of hydroxychloroquine. The advanced countries which goes by the rational and the approval process, whatever may come, what may not come. We cannot have many QT intervals in a non-COVID patient. It's not the only disease which is it exists. The fear or the panic is making it more dreadful, no doubt about it. But at the same time, we cannot ignore that. We cannot have more QT intervals at the population level without the fault of a patient who consumes by the wrong rumors. That's so disastrous. And this is my personal opinion. How can prophylaxis for a viral disease? It's a myth. It's a false insecurity where one can get an overconfident, zealous, especially for the medical professionals. One has to be very, very cautious, very, very cautious. It's not just the availability of PPE, but the quality and the procedure of utilizing it. Because if you look into the Western world, how the initial days the Chinese reports were coming, we have to accept that Western world, as far as utility of these equipment, they're probably more trained, more better off. I don't know, whether we were exposed to this infrared thermometers also. Where are the skill sets who is actually recording this temperatures, and then we blame that person has run away from the airport, hiding in washroom, etc., all this. So we have to be very cautious overall, in utilizing judicious utilization.
So, any other questions that are coming up?
Uday, can you tell certain?
Doctor, from the chat, there is a one question which is coming. Is there a specific effect of coronavirus on autoimmune disorders?
So as far as the current knowledge goes, the autoimmune disorders are not getting particularly affected by the coronavirus, nor is the presence of autoimmune disease affecting the severity of coronavirus. At least we don't have clear reports to this count. So at least on those counts, it's okay. It's really the cardiovascular disease, cerebrovascular disease, hypertension, diabetes, and COPD, which are the real problematic areas.
Thank you, sir.
Doctor, I have one small question which propped up yesterday. And the question is that there are various reports saying that the virus lives or keeps alive itself onto various surfaces. What is the duration this virus is alive? I mean, if we go to buy some grocery or fruits or touch our lips button or the handles, what do you have to say about it?
So this, it can stay on surfaces, and the time that it can stay on surfaces is actually different. So on some surfaces, it can stay for just about a few hours, but on some, it can last as long as 4 to 5 days also. And all this talk about the temperature and that we are more protected because it's a tropical country, this is all conjecture. We don't know for sure that the virus is destroyed. So that is why frequent hand cleaning and hand hygiene, particularly as you return from anywhere outside, or if you have touched surfaces which could have been contaminated, this is important because ultimately the virus has a fat cover. The envelope is fat, and if you use soap and water, the envelope is destroyed. So a good hand hygiene
Okay.
with soap and water or alcohol-based solutions. That is the real key. And the key is not to keep touching your face, uh, as is wont to be done by many people, as I said, almost 5 times every minute.
Mhm. Great. Sir, there is one more question from Dr. Swati Dole. She asked, where are on the timeline with respect to COVID-19 outbreak, maybe in comparison to Italy or the US?
So this is a question, as you can see here, as you are all aware of how the cases exponentially increased in Italy. The doubling time was so rapid that within a space, I mean, actually, the US started reporting cases maybe just after us or along with us. But you can see that they already have crossed 100,000 cases. So their rate of the rate of doubling of cases has been quite rapid. In Italy, they did not take care of social distancing when the first cases started to appear. Again, their cases have rapidly increased. As I said, at least right now, since we are at our homes, new clusters are not coming. And as I said earlier, also the WHO has said that new areas, new countries have not come up. As far as India is concerned, we are already into a lockdown for the past several days. We still have till almost 15th of April to go. And only the coming days will tell us, because we still are getting new cases from, previously unknown sources. So there were people who had traveled but had not revealed their history. There are people who are migrating from towns to their villages. We still don't know exactly where we are. And only the next few days will tell us how the cases are going. But at least in the last few days evidence that we are not going the Italy way of rapidly increasing, hundreds of cases every day. That's all that I can say from whatever limited knowledge I have about this subject.
Thank you, sir. I mean, that was very elaborate answer to that question. This is a non-medical question. There is one from Dr. DK. He is asking, considering the all characteristics of the COVID-19 virus, do you think this is a biological weapon used by some country?
See, I mean, this is a very frivolous question to ask also. And I think enough of this is available on the social media. As doctors, whatever way this came into the being is hardly our concern, honestly. And as doctors, as health professionals, our responsibility is to now do what we can to prevent large numbers from occurring, and whatever patients have been affected, to take good care of them and to take care of ourselves. How it came into this world first time, I don't think we will ever know, and nobody will ever know.
Right. Sir, there is one more question. I think it is relevant, saying that does the patient recovered from COVID-19 still be susceptible to the other infection?
Of course, he's susceptible to other infections because he has undergone a very major thing in his life, and particularly superadded bacterial pneumonitis is a very, very, very valid concern. These patients still have to be careful about what they do. It's not that they, just because they have had a small infection and just come out of it, that you can go out and do anything. They still have to be careful, and particularly in the infected stage, they are at a serious risk of developing secondary bacterial infection. So that's very definite.
Great. Sir, I think questions could be many, but I think we already have almost an hour of the discussion. At the outset, let me express my sincere gratitude to you for being agreed to deliver this fantastic deliberation at such a short notice. Dr. Navneet Wadhwa, thank you very much. Dr. SVK, very sporty of him. He said, I would like to join today. He is doing it for the entire Konkan on Tuesday, sorry. Tomorrow, Dr. Panikar is doing it in Mumbai. So a lot of things going across. So thank you very much, sir, for being the part of this. And it was really wonderful to have you on chat.
And thank you, Sanjay, and your entire team for actually thinking of this and bring it about.
Thank you very much.
Thank you.
Thank you so much, sir. Thank you, Dr. Uday Phadke. Thank you so much.
Thank you, sir. Thank you. It was wonderful.
Thanks, audience,
Thank you,
also
That's
Right.
all the delegates for attending.
Yeah,
Thank you, sir.
I thanks everyone to be the part of this wonderful and very crucial topic. I think as much as we could, and with the latest information, we could do that. Thank you very much. Thanks a lot.
Thank you. Good night.
Dr. Esriki, anything else?
No, just wanted to stress one point that if
Yeah.
the patient is having fever
Yeah.
and if he is not responding to paracetamol for a routine dose, increase the dose to 650 milligram 3 times a day. But
Yeah.
don't give a cocktail like ibuprofen or Disprin to that patient. These people go into very severe hypothermia.
Okay.
Their fever remains on one side, diabetes remains on the other side, and the patient needs to be treated for severe hypothermia.
Beautiful.
And Combiflam is a very combination used by all the people as a OTC. And Disprin is available with practically everybody. So this is something which I have faced in last 1 or 2 months. At least 5 to 6 people who have taken odd combinations of antipyretics and developed complications.
Thank you very
Avoid
much, Dr.
ibuprofen.
Kulkarni.
nice
Thanks a
information.
lot. I think that was wonderful addition by you. I once again thank all the participants. I also thank Vinod, Suhas Pandey, Prashant Kulkarni, and all my team members here to make it possible. We are looking forward. I think our Vice President has also joined, Avinash Vani. Avinash, I hope you like the deliberations here. And we would talk offline as well. Thank you very much, guys. Thanks a lot.
Thank you, sir.